Good morning. Today we're going to discuss the respiratory system in pediatric population. But before we go into the actual disease process, let's review a little bit of the anatomy and physiology of the respiratory system and the pediatric airway. Pediatric is not just a little adult when it comes to airway anatomy. In fact, there are many differences often overlooked in general practice, especially those clinicians that don't know the difference. There is very special consideration in anatomy when it tends to alleviate respiratory distress and ensure that there's a definitive airway open in a timely manner. First, the ribs of the infant and young child are more horizontally oriented, making anterior-posterior displacement of the chest less during inspiration. The rib cartilage is more compliant in young patients than in older children and even adults. So during episode of respiratory distress, the chest wall may actually retract easier, decreasing the child's ability to maintain functional residual capacity. The intercostal muscles are not fully developed until school age, acting primarily to stabilize the chest wall. They do not have the necessary strength to lift the ribs. As with the adult, the child chief muscle of respiration is the diaphragm. However, the muscles of the diaphragm are more horizontally to the ribs as opposed to oblique in the adult. This places the infant and the child in having compromised diaphragmatic function and contraction when it's necessary in respiratory distress. So elevating the head of the bed improves diaphragmatic function and may completely alleviate paradoxical work of breathing in the children. Children tend to have a large occiput that can compromise the airway. So if you flex, if you put the child or the neonate in the examining table in a flex position, this could obstruct the airway. So try always to, in that particular age group, place the small roll behind the shoulders to maintain airway neutrality. The common sniffing position works very well for adolescents and adults. Infants and young children also have a large tongue in comparison to the oropharyngeal space. So they have a predisposition to soft tissue airway obstruction from the tongue. This is always a possibility. Infants and younger children are predominantly nose breather. Pediatric patients who present with respiratory distress that have an upper respiratory tract infection may have an ineffective ventilatory pattern. Simple nasal suction may alleviate this stress. They have a very small internal diameter of the airway, so foreign objects tend to allocate easily in the trachea. Perhaps the best known anatomy difference in neonate and pediatric patients is the cricoid cartilage. The narrowest portion of the pediatric airway is the subglottis. The airway itself is funnel shaped as compared to the cylinder shape of the adult. So this again tends to predispose the patients to have more airway obstruction and allocation of foreign body aspiration. The adult airway is cylinder. The infant and pediatric epiglottis is typically floppier and articulates at a more acute angle with the larynx. The epiglottis will be more difficult to displace with a laryngoscope in the pediatric population than in adult. Children tend to have a very high airway resistance. Let's talk about the possible signs and symptoms and normal respiratory rate. Respiratory rate, is just like a heart rate, is the single way in which young children are able to effectively improve their cardiac output. An increased respiratory rate may be the only sign of increased work of breathing. Tachypnea, for example, in a patient at a rate of greater than 60 is an ominous sign of respiratory muscle fatigue. Bradypnea, as well, in any patient, um, is a sign of central nervous system impairment, but in addition, respiratory distress and hypoxemia. Take note of the physiological normal of the respiratory rate by age. Typically, the neonate is 20 to 40 breaths per minute. Children is 20 to 30. An adolescent is 12 to 20 like an adult. A normal respiratory rate is inversely proportional to the patient's age. The younger the patient, the higher the expected respiratory rate. So as a clinician, you will be less concerned about a neonate breathing at a rate of 60 breaths per minute than a 10-year-old, for example, child. Examples of symptoms that could be present indicating respiratory distress will be nasal flaring, and it's very common across all age group. Do not brush off moderate nasal flaring in an infant as nothing when performing a respiratory assessment. Take note and use other clinical indicators. For example, grunting. It's very similar to pursed lip breathing in adult. Grunting is a way in which the neonate and young pediatric attempts to maintain an open airway, essentially splinting the airway in an attempt to prevent air collapse and improve oxygenation and ventilation. Stridor is another one, as in all patients, stridor denotes an upper airway obstruction. On assessment, you should know the quality of the stridor. Very important piece of the assessment is the auscultatory findings. For example, if you have fine crackles could be a sign of inflammatory conditions such as asthma or even pneumonia. Dry crackles is a chronic condition like pulmonary fibrosis, and wet crackles could also indicate that the patient has fluid in the lungs, such as in pulmonary edema or pleural effusion. Level of consciousness. While it may be not be routine to do central nervous system scoring on a children upon respiratory admissions, it's very important that you grade the level of consciousness in the pediatric population as well. And this could be only done with a system that uses the acronyms AVPU, which is A for awake, V as in Victor for verbal, P for pain, U as unresponsiveness. Keep in mind the baseline. This is more important. When you walk inside the room, look up and greet yourself. Are they responsive to parent? Are they smiling, grouchy? Changes from the last time that you saw. If you're familiar with the patient, beware of the agitated child who cannot be consoled. Look at the high-pitched cry as well. Look at the color of the child, the temperature. These are anatomic divisions of the respiratory tract. Remember that the upper respiratory tract is composed of the nostrils, the nasopharynx, the larynx, the upper trachea, and the eustachian tubes and sinuses. So today we're going to talk about laryngeotracheal bronchitis. We're going to talk about sinusitis and as well rhinitis. And we're going to talk about lower respiratory tract, which entails the lungs. The respiratory tract is also mediated by active and passive immunity, and lysozymes IgA and IgG prevent and fully support the immune system of the respiratory tract. The sinuses are not fully developed. Maxillary, for example, until 4 years of age. Ethmoid until birth. And sphenoids at 6 to 12. So a child at 6 months of age could have ethmoid sinusitis, but not maxillary sinusitis. Type 2 pneumocytes, you know that they are in charge of production of surfactant. They're not fully developed or formed until week 28. Now, talking about history and physical, very important, and in your book is very well described that besides obtaining the history of the present illness and physical examination, it's very important to go and assess manifestations that could be present that can lead you to important data to obtain your differential diagnosis. For example, history of the present illness is composed of PQRST, and P, for example, is the promoting, preventing, presenting, precipitating, and palliative. Ask the family if the child is attending to a daycare or to a school, because you would see the pneumonia is not the same treated if it's community acquired or if the patient resides or visit very often daycares, which is more treated as institutionalized or nosocomial pneumonia. The same as adult, it's not the same treating the patient with pneumonia outside in the community at home versus a nursing home. Is the mother or the father or the caregiver giving already over-the-counter medications like vitamin C and the common cold has not improved? Are the respiratory symptoms associated with fatigue, or is it getting worse? It's very difficult to sleep because the cough is paroxysmal. Quality. How severe are the symptoms? Is there any associated symptoms or radiation? For example, if the patient has pneumonia, patients could have chest pain due to pleurisy. Is this shortness of breath or the productive cough associated with pleurisy? Other signs and symptoms that could manifest that there's a major systemic condition going on, such as fever, such as poor feeding. Any similarities of the same disease in the past, any associated disease, any immunocompromised disorder. How long has this condition last? Or any family history of the disease process. For example, you would see that asthma is an hereditary condition, so it's very important to note if the family has asthma as well, or fever, any type of allergies. Now, before we go here, let's talk about physical examination. What could you see on the physical examination in general? Look at the respiratory rate, look at the depth, the ease, the symmetry, and the rhythm of respiration. In young children, an elevated respiratory rate may be an initial indicator of any type of hypoxemic event. Look at how inconsolable the patient is. Any inconsolability, any respiratory effort, the color, if there's any cyanosis, if there is any interaction, any playful child. Palpation, look at the tracheal position, look for symmetry of the chest, look at vibration or vocalization of these sounds. Look at any shift of the trachea that could indicate pneumothorax. Palpate, look at if there's a presence of tactile fremitus that could lead to consolidation. Auscultation wise, listen to the quality of the breath. Listen for fine or coarse crackles, wheezings, rhonchis. Remember that wheezings or prolonged expiratory time could indicate airway obstruction as well as obstructive pulmonary disease such as asthma. Tachypnea, any indicator that there is a decreased lung compliance. Any transmitted voice, remember that whisper perturbology and egophony. In health assessment, we studied that this is related to a lung consolidation, either a tumor or pneumonia. Percuss, look for tympany. In this case, basically resonance or dullness to percussion. Remember that tympany is airway obstruction as well. It's a hyperexpansion such as asthma or chronic pulmonary disease. Or dullness to percussion basically represents consolidation or fluid. Common cold. Remember that common cold is not a similarity of influenza. Common cold is an acute, is usually afebrile, is self-limited viral infection causing an open upper respiratory symptoms such as rhinorrhea, cough, sore throat. About 50% of cold are caused by a serotype, which is rhinovirus. It could be also present coronavirus or adenovirus, but the most common that produces common colds is the rhinovirus. The symptoms, most of the time after an incubation period of 24 to 72 hours, symptoms begin with a scratchy, sore throat, sneezing, rhinorrhea, or nasal obstruction, or either malaise. Temperature is usually normal, particularly when the pathogen is a rhinovirus. Nasal secretions are watery, could be profuse during the first few days, but then could become mucoid or purulent. But mucopurulent secretions never indicate in this patient a bacterial superinfection unless it's associated with other manifestations more systemic. Okay. Susceptibility to colds is not affected, as previously thought in the past, to cold temperature. You could be exposed to cold weather and there is no necessarily an indicator of that you are mostly predisposed to common cold. Not even the health or nutrition of the patient, not even having enlarged or tonsils or adenoids. That was a prior thought. Diagnosis is very, most of the time clinically, presumptively, without the need of any diagnostic test. Allergic rhinitis is the most important consideration for differential diagnosis. Patients have an allergic reaction and they will be constantly sneezing and having also watery nasal discharge. Treatment, there's no specific treatment. Antipyretics and analgesics may relieve fever or sore throat. Nasal decongestants could also be used. Try to avoid anything that contains norepinephrine because remember it can give in any patient, not only pediatric, hypertension and also rebound congestion. Rhinorrhea could be relieved by antihistamines, but are not recommended for children less than 4 years of age. So cough medications could be used, but remember that cough is only blunted if impedes the ability of the child to sleep. Patients should be encouraged to increase fluid intake, have zinc, vitamin C, have humidified air, and even echinacea. There are no vaccinations for common cold for rhinovirus. Patients should be encouraged to eat fruits, vitamins, and antibiotics never are prescribed for common cold. This is a viral condition. Now, influenza is, even though it's very much confused with common cold, it's not the same. It's also a viral respiratory infection causing fever, coryza or coryza, cough, headache, and malaise. Mortality could be high during seasonal epidemics, particularly among high-risk patients such as extreme age, neonates and young infants, institutionalized patient. If this pediatric patient has a cardiopulmonary insufficiency, patients could even die. Everyone aged more than 6 months should receive an annual influenza vaccination. Influenza antigens, viruses are very common. The most common are type A, B, and C. A and B are the one that are discussed in this PowerPoint because influenza C does not cause the typical influenza illness, so it's not going to be discussed here. The antigen itself is a glycoprotein that allows virus to bind to the cell and fuse to the host cell membrane. They release a neuraminidase, which is a glycoprotein that promotes viral release from the infected host cell. This antigen has a drift and a shift that could explain why patients get the influenza vaccination and possibly get the influenza infection. Basically, there's mutations that results in emergence of a new viral strain. This new strain may cause seasonal epidemics because protection by antibody generated to the previous strain is decreased, or um, because antibody against other strains provide little or no protection at all. So the shift refers to the relatively rare development of new combinations of hemagglutinin, which is the glycoprotein that produces the virus, and that's the reason why sometimes pandemics could occur. Very rare up to 2013, where six major pandemics occur. And if you remember, for example, the 2009 swine influenza, H1N1 that occur. Influenza virus is actually transmitted by airborne droplets or person-to-person contact, or basically contact to contaminated items. A risk group are less than 4 years of age, and of course adult more than 65. So that's the population that is targeted to influenza vaccination, even though everyone more than 6 months of age should be vaccinated. In addition, if the patient has any other chronic medical conditions such as cardiac diseases, diabetes, or renal or hepatic insufficiency, or any type of immunodeficiency, of course, and if the patient cannot handle respiratory secretions such as in cystic fibrosis or seizure disorders or any type of neuromuscular disease, is also a risk population. Symptoms after the incubation period of 1 to 4 days. Um, Patients complain of sore throat, rhinorrhea, mild conjunctivitis, um, up to fever, chills, prostration, cough, generalized aches and pains, headache, photophobia. Is actually most commonly mild, with a scratchy sore throat and substernal burning or non-productive cough or coryza, but it could go up to the prior described symptoms. Most likely subsides by itself, so it's self-limiting. Children may present with nausea, vomiting, and abdominal pain, and even with sepsis in young infants. Complications could be from pneumonia to encephalitis and even myocarditis. So you have to be very attentive to worsening cough or bloody productive sputum or worsening of dyspnea and even rales. That is a sign of pneumonia. Diagnosis is mostly by clinical evaluation. Um, Very well known to be present in the community. So if many patients surrounding the pediatric patient have the flu, it most likely is an indicator that that's the illness present. Um, but again, there's no need to do a chest X-ray unless patient has signs and symptoms of lower respiratory tract, such as dyspnea, rales, or hypoxemia or productive cough, high fever. Treatment is mostly symptomatic. Try to avoid aspirin in children less than 18 years of age because of Ray's syndrome. Influenza, antiviral could be given, and choices is oseltamivir, Tamiflu, or zanamivir, Relenza. Those are neuraminidase inhibitors. Remember that the actual virus released that and glycoprotein. Um, So if you inhibit that glycoprotein, then the virus is not going to be attaching to the host cell. Or an adamantane, which is the muscarinic antagonist. So basically, the respiratory secretions um, could be diminished, but the main side effect will be, tachycardia and all the nicotinic receptors side effects. Prevention is biannual vaccination. It's the CDC recommendation. And this is basically covering the strains of influenza A, 1 and 2, A and B. Now, pharyngitis, or most commonly called sore throat, is pain in the posterior pharynx with or without swallowing. Could be from mild to severe, and patients most likely complain of sore throat and refuse oral intake. Um, it could be from viral infections or bacterial infection. The most common viral infection is adenovirus, but others that are present are rhinovirus, influenza, coronavirus, and respiratory syncytial virus or RSV. The main bacterial cause is group A, beta hemolytic streptococci, and this is the one you have to be attentive because of the common consequences of um, myocarditis, cardiomyopathies, and even glomerulonephritis. It's a very high concern. Other causes could be diphtheria that we're going to discuss here today. It's very important also to rule out abscess and epiglottitis when the patient has pharyngitis. Um, Epiglottitis is actually one of the major complications. It's life-threatening. It's usually caused by Haemophilus influenza. We have a slide here that we're going to discuss this in particular. So basically go and examine the patient, go through the review system. In the history, of the present illness, most likely complaining of severe sore throat, from mild to severe sore throat. But be attentive to if the patient has difficulty breathing or difficulty speaking. Most likely these patients complain of runny nose, cough, and sore throat, never up to weakness and malaise, suggesting mononucleosis, for example, or lymphadenopathies. In the past medical history, be very attentive to document any immunodeficiencies that could put the patient even at higher risk. Any sick contact with group A, beta hemolytic streptococci. In the physical examination, patient should note if fever is present, if any signs of respiratory distress such as tachypnea, dyspnea, stridor, any awkward position such as tripod position, sitting upright, leaning forward with the neck hyperextended or the jaw thrust forward, that's a sign of respiratory distress. Physical examination should never be done in a child suspected with epiglottitis, so never open the pharynx and never examine the posterior pharynx with a tongue blade depressor, because that could trigger complete airway obstruction. Look for erythemas, look for exudates, look for any swelling of the tonsils or any lymphadenopathies that could lead you to a different diagnosis. So the following findings are particular of concern, and those are called red flag. If the patient has stridor or any other sign of respiratory distress, any drooling, any muffled hot potato voice, or any visible bulging of the pharynx, because that could lead to either epiglottitis or pharyngeal abscess, which are the most common concern differential diagnosis. For example, if the patient has epiglottitis, there's an abrupt onset of severe throat pain and dysphagia, usually with never ever preceding upper respiratory symptoms. Patient has never have cough, no nasal discharge, and all of a sudden has severe throat pain and dysphagia. Children with epiglottitis are drooling and have signs of toxicity. They're more tachypnea, dyspneic, and having stridor. They're more in tripod position. If you're thinking about pharyngeal abscess, they have erythema, exudate. They have that hot potato voice. They have deviation of the uvula. So be very attentive to the clinical criteria, and you could give points to it. I'm going to show you the actual criteria now. So but basically is tonsillar exudates, tender lymphadenopathies, fever, or absence of the cough. If there is less or one point, then presumably the patient has viral pharyngitis. If there is two or more in the criteria, most likely the patient has group A beta hemolytic streptococci, and most likely warrants antibiotic treatment. So basically, these patients with group A streptococci has fever, sore throat, lack of cough. This is super important to remember. Lack of cough or nasal symptoms. Petechia on soft palate, exudates, and tender and enlarged lymphadenopathies. The diagnosis is only the actual diagnostic specificity, and the most definitive diagnosis is only by throat culture. But meanwhile, um, a rapid strep test could be done um, for the clinician to rule out viral diseases, and if it's positive, most likely the patient has group A streptococci, but if it's negative, since it has a very low sensitivity, could be a false negative. So if there is highly clinical indicators that the patient has group A beta hemolytic streptococci, I'll show you now the algorithm that the guideline recommends. So if it's negative and you have highly clinical suspicions, go ahead and do throat culture. If that throat culture is positive, then treat. But if the rapid strep stat is positive, then immediate antibiotic treatment should be initiated to prevent glomerulonephritis and cardiac diseases. Treatment, if it's viral, depending on the points, is supportive, and if it's positive for rapid strep test or culture, antibiotics should be started. This is the point criteria. If there is absence of cough, you give 1 point. If there is lymphadenopathies, you give another point. If there is high temperature, another point, or exudates, 1 point. And the age of the patient, the younger the patient, the higher the points. So if you get less or equal to 1, no further testing, most likely is viral. If you have 2 or more, then you do throat culture or rapid strep test. If the rapid strep test is negative and you have highly clinical suspicious, you have to do a throat culture. Otherwise, if there's no clinical suspicious, no antibiotic is indicated. But if the culture is positive, then you continue with antibiotic. If the rapid strep test is positive or the culture is positive, obviously you're going to start antibiotic treatment. Or if the score is higher than 4, then antibiotic treatment should be initiated, even without the cultures and rapid strep test. This is the guideline recommendation for treatment. Penicillin V is the first initial treatment of choice by guideline. In addition, amoxicillin could be given, or penicillin G, for patients that have allergic to penicillin with a type 1 hypersensitivity reaction anaphylaxis. With type 1 hypersensitivity reaction anaphylaxis, you have to choose Clinda, azithromycin, or clarithromycin. If the allergic reaction is not type 1 hypersensitivity reaction, a third generation cephalosporin could be given, such as cephalexin or cefadroxil. Now let's talk about sinusitis. Sinusitis is an inflammation of the paranasal sinuses and also could be due by viral, bacterial, fungal, or even an allergic reaction. Symptoms basically include nasal obstruction, congestion, purulent rhinorrhea, facial pain or pressure, and even sometimes malaise and weakness. Sinusitis most commonly is classified as acute when it's less than 30 days, subacute 30 to 90 days, recurrent when more than 4 acute episodes per year are happening in recurrent cycles, and chronic when lasts more than 90 days. Um, there's acute and chronic sinusitis. Acute sinusitis in immunocompetent pediatric patients is almost always viral, and this is due by rhinovirus influenza or parainfluenza. Very small percentage is by bacterial, and if it's present, is streptococci, pneumococci, Haemophilus influenza, or Moraxella catarrhale, as you studied before. Uh, Occasionally, it could be done by dental abscess. And when that happens, you have to think about anaerobic and gram-negative bacteria such as Klebsiella and Proteus and Enterobacters. Chronic sinusitis could be done by anatomical abnormalities such as nasal polyp or environmental irritants such as pollution or tobacco. The pediatric patient doesn't smoke, but the passive smoking of the parents could produce sinusitis. Mucociliary dysfunction, patients with cystic fibrosis have that, and you have to think in this case of a very polymicrobial infection with gram-negative bacilli as well. Aspergillus, for example. Chronic sinusitis could also be due by allergic reactions. So patients that have, asthma and allergic rhinitis. Risk factors include obstruction of the normal sinus drainage, allergic rhinitis, nasal polyps, even gastroesophageal reflux disease, diabetes, and any dyskinesia of the ciliary to expel the secretions, such as in cystic fibrosis. The swollen nasal mucous membrane obstructs the opstium and the paranasal sinuses. So the oxygen in the sinuses is absorbed into the blood vessels of the mucous membrane. This results relatively negative pressure in the sinuses and is very painful. If the vacuum is maintained, a transudate from the mucous membrane develop, and this could produce accumulation of mucus and bacteria, and it could even produce hyperemia and edema, and as complication, patients could get cellulitis. Symptoms, again, were discussed. More commonly, rhinorrhea, pain in the face, nasal congestion, halitosis, even decreased smell sensation, which is called hyposmia. Patients could have tender sinuses upon palpation. Transillumination is not recommended in pediatric population, and they don't cooperate unless there is a old child. Nasal mucous membrane is red, and but it could be also yellowish due to rhinorrhea, mucopurulent. Manifestations of complications that you have to look for is periorbital swelling. If there is periorbital swelling, you have to rule out orbital cellulitis from sinusitis. Proptosis, meaning that bulging of the eyes, any extraocular muscle paralysis, any decreased level of consciousness, any severe headache, any fever that doesn't go away. Clinical diagnosis is mostly relevant, so this is due by clinical signs and symptoms. Imaging is not indicated in acute sinusitis unless there are findings suggesting a complication, or if there is any immunodeficiency. If the patient is immunocompromised, then it requires it. Bacterial sinusitis is suspected when purulent rhinorrhea persists more than 10 days, along with fatigue and cough. Fever is very uncommon in pediatric populations, so have that in mind. Local facial pain or discomfort may be present. Nasal examination discloses a purulent drainage. Again, diagnosis is clinical. CT is avoided because of concern of radiation exposure unless there are signs of complications such as periorbital swelling or vision loss, or any paraplegia of the extraocular muscles, or if there is an unilateral nasal obstruction that you might think of a foreign body or cancer, any pain, any epistasis, any diminished vision. Treatment is enhancing drainage, so you could do steam or you could do topical vasoconstrictors, although they're not recommended in pediatric population. And the guideline says that the first line of treatment for sinusitis is amoxicillin. If you remember in pharmacology, for almost always all the upper respiratory tract disease, amoxicillin is the first line. For sinusitis, for otitis, for pharyngitis, even though we already discussed that penicillin is the first line for pharyngitis, but amoxicillin could also be used. For patients who are allergic to amoxicillin and they do not have a type 1 hypersensitivity reaction, ceftinir or cefuroxime, which are cephalosporins, can be used. If it's a type 1 hypersensitivity reaction, then you have to use clarithromycin or azithromycin. In addition, you could use decongestants, corticosteroids, humidity. Surgery is only required for chronic and recurrent sinusitis to improve sinus drainage. And if the patient has any systemic manifestations of worsening, then either ENT referral for sinus aspiration or hospitalized for IV antibiotic. Now let's talk about diphtheria. It's an acute pharyngeal or cutaneous condition because it could be manifested either or. It is basically due by a toxigenic strain of the corynebacterial diphtheria. And symptoms, again, could be very non-specific, from skin to pseudomembranous pharyngitis. But the most likely complication is myocarditis and also CNS involvement. Basically, it's very rare. Humans are the only known reservoir for corynebacterial diphtheria, and it's spread by respiratory droplets, by contact with nasopharyngeal secretions, by contact with infected skin lesions, and even fomites. A carrier state is common in endemic regions in countries such as Africa, South Africa, Asia, and even Haiti and Dominican Republic. Symptoms is whether the toxin produces enough to produce respiratory infections, which are the most common, or cutaneous manifestations. After an incubation period, more or less 5 days, patients develop sore throat, but mild. The exudate of the nasopharynx, as you could see, is very dirty looking, gray, tough, fibrinous, very adherent, that if you try to dislodge that, it's going to cause bleeding. It produces a lot of local edema, swelling of the neck that is very pathognomonic, which is called bull neck, B-U-L-L, hoarseness, stridor, and even dyspnea. The membrane could extend up to the larynx and trachea and the bronchi, obstructing. As if the skin is present, or in addition, patients could have fever, barking cough, but I don't want to mention the barking cough because I don't want you to confuse with croup, sore throat, difficulty swallowing, and swollen lymph nodes. Remember the swollen lymph nodes? Remember the grayish membrane in the throat. This is the skin manifestation, which is, it could vary in appearance, but most likely is a non-healing punched out ulcer looking with also the same grayish membrane. You don't see the membrane here because this was already cleaned, but it could also be presented as eczema, psoriasis, and it could even look as impetigo. Very painful tenderness with erythema. Complications, the main complications are myocarditis, and patients could even have alterations of motor and sensory deficit with demyelinization and polyneuropathies. This is the bull's neck. Diagnosis is by stain and culture. Um, Diphtheria needs to be considered in patients with non-specific findings of pharyngitis, with cervical lymphadenopathy, with low-grade fever, with the hoarseness, par- paralysis of the tonsils, with that gray, dirty-looking membrane. Is very suggestive of the diagnosis. Cutaneous diphtheria could also be cultured. Remember to do an EKG because of the presence of myocarditis. Um, Symptomatic patients with respiratory diphtheria should be hospitalized in the ICU and monitored not only for respiratory distress but also for cardiac complications. Isolation with respiratory droplets and contact precaution is required and must be continued until two cultures taken 24 to 48 hours apart after antibiotic are stopped. So if that is negative, the isolation could be lifted. Treatment is based on the diphtheria antitoxin that must be given without waiting for culture confirmation because the antitoxin neutralizes only toxin, not yet bound to the cells. So you don't want the cycle to continue. The use of antitoxin cutaneous disease without evidence of respiratory distress is of questionable, but it doesn't matter. Just give it. More or less is from 20,000 to 100,000 units IM or IV. If the patient has striders, use racemic epinephrine. You could also use antibiotics such as penicillin or erythromycin. Vaccination is required after recovery for patients who had diphtheria because infection does not guarantee immunity. Recovery is very, very, very slow. So be attentive to that. Um, Everyone should be vaccinated at prescribed intervals. Remember the booster for adults. Now let's talk about EPIXTASIS. It's very common in pediatric population, um, and the most common cause is actually picking and trauma. Epistasis is nose bleeding. Bleeding can range from a trickle to a strong flow, and the consequences can be mild to life-threatening. Remember that these patients tend to swallow the blood, so they could also vomit the blood, or they could see blood in their stool. Okay? Most nasal bleeding is anterior and mostly originates from the plexus that is called Chiesa-Botch area. Less common but more serious are posterior bleeds, and you also have to look at systemic manifestations that can lead you to that. The most common cause of epistasis in any population is local trauma, and this is by nose bleeding or picking, or even drying of the nasal mucosa. There are a number of other causes that you have to have in mind, and that is from rhinitis to foreign bodies to even systemic manifestations that could cause dyscrasias. You have to basically determine when did the bleeding began. Most patients can have the localized bleeding in one side. If the patient's sneezing, have you blow your nose? Have you pick at your nose? Those are your first questions to the parents or the child. Look for any nasal obstruction, any nasal or facial pain that can lead you to think that the patient has a foreign body. Look for any excessive bleeding, including easy bruising or tarry stools or hemoptysis or blood in the urine. So the presence of any bleeding in other sites is a red flag. Any history of using aspirin. I know that the child doesn't is not or should not take aspirin, but any type of medication or any natural element or herb that by culture is given to the child, any aspirin containing products, or if the child has a cardiac condition, is on any anticoagulation therapy that could lead to the cause of epistasis. Look for any sign of volume depletion, such as tachycardia or hypotension. Um, that's a red flag as well. Any anticoagulation use, as I said, um, any bleeding that doesn't stop with direct pressure. To be able to treat presumptive treatment for active bleeding patients is that of the anterior bleeding. The need of blood replacement is determined by hemoglobin level. So it's usually very well controlled by pinching the nasal ala for 10 to 15 minutes while the patient is sitting upright. You could use humidifiers to avoid a dryness of the nose. Topical antibiotics or Vaseline is not because there's an infectious process going on. It's basically to humidify, to coat the nasal mucosa. You could use bacitracin or mupirocin. Never use try not to use neosynephrine, nose bleed QR, because that could produce, yeah, it stops the bleeding, but can give you vasoconstriction and hypertension if it's absorbed systemically. Other methods could be a silver nitrate stick or nasal packing. Teach the parent not to remove the scab, because that could lead to constant bleeding. Now, let's talk a little bit about foreign body aspiration, mostly in the airway. Basically, it's present in 75% of children less than 3 years of age. Very, very common. Most commonly in the nasal area, the intellectual impaired, and even psychiatric patients. Common objects that could be pushed could be cotton, paper, beans, seeds, nuts. The most common are the nuts, the peanuts. Minerals could also be placed there, like stones. Nasal foreign body suspected in any patient with a unilateral, foul-smelling, bloody, purulent rhinorrhea. It could be associated with other respiratory symptoms, such as sudden respiratory distress, any history of chronic paroxysmal cough, shocking of sudden onset as well. The triad, which is very common, of coughing, wheezing, and decreased or absent breath sounds, is present in more than 40% of cases. Patients could also present with stridor, tachypnea, retractions, rale. It could be misdiagnosed as well, confused with other disease process. Nasal foreign body can sometimes be removed in the office by nasal speculum, nasal forceps, but try not to if you do not see the object, because it could be lodged in the trachea or in the airway. So that is only done by bronchoscopy. You could do an AP or lateral decubitus to be able to see the objects. This is an X-ray with the foreign body, and even though you don't see the foreign body right here, this is an illustration that where the foreign body is located, you would have an atelectasis. That's white area is an atelectatic lung, and hyper expansion of the contrary side. In addition, here you see mild atelectatic area here and hyper expansion on the contrary side. This is another foreign body allocated in the right main stem and hyper expansion. This is esophageal, a coin, and another coin. Look, this is a tiny, tiny airplane. Treatment of choice, never try to remove it unless it's nasal and visible, always by bronchoscope. Any medication is discouraged. Bronchodilators and corticosteroids are not going to do anything, not even antibiotic. You could do chest physiotherapy to try to dislodge the material, but majority of the time doesn't work. Pneumonia. Pneumonia, now we're going to the lower respiratory infections. Pneumonia is basically, it could be viral or it could be a bacterial infection as well. The most common pathogens identified, as we previously stated, is streptococci pneumonia, but Haemophilus influenza could be present, and even atypicals such as chlamydia, mycoplasma. Is remembering a health assessment, consolidation of the alveolar space. So it's the leading cause of death in children under than 5 years of age. A lot of hospitalizations this year. 13% of all infectious diseases in infants are in younger than 2 years of age. So very, very common. Majority of cases are viral, so it is self-limiting, and those are RSV, respiratory syncytial viral influenza, cytomegalovirus, and parainfluenza could be present as well. In neonates, bacterial infections or the group A beta hemolytic streptococci, but also gram-negative, as I said, could be present. In 1 to 3 months, staph aureus, but strep pneumonia is also present. Even though it changes the microorganisms, the strep pneumonia are the one most common. Even though mycoplasma, for example, could be present, and chlamydia in more than 5 years of age. So you empirically will start treatment based on strep pneumonia and Haemophilus influenza, and if the patient doesn't improve, then you could change. Associated symptoms are basically malaise, chills, rigor, fever, cough. This cough is productive, most likely yellowish, rusty color, or greenish. Dyspnea, even chest pain could be present, or chest discomfort, because pneumonia could produce pleurisy. Cough typically is productive in older children and adult, and dry could be in infants. Dyspnea usually is mild and exertional when the child is playing. The chest pain again is pleuritic in nature, mostly in inspiration and cough. But it could also be manifested as upper abdominal pain with nausea, with or without vomiting. Remember that the lower lobes are touching the diaphragm, so patients could present with abdominal pain and have bilobar, bibasilar pneumonia. Diarrhea could also be present, restlessness, confusion, altered mental status. Remember the bronchial breath sounds in physical examination, such as egophony, which is the change of an E to an A during auscultation. Also, whispery perturbologia, dullness to percussion. Be attentive to nasal flaring and accessory muscles. Infants could have a high fever or not. Pleuritic chest pain, remember that chlamydia is one of the highest in them, even though strep pneumonia could be present. Nasal flaring, grunting, or retractions could also be present in both populations. Tachypnea or tachycardia, or air hunger. Fine crackles could also be present, because remember, any type of infection could leak fluid to the outside. Be attentive to possible complications of systemic infections, sepsis, or meningitis with nuchal rigidity. Other differential diagnoses could be asthma or cystic fibrosis, and even TB. Um, how do you diagnose? Is suspected on basis of clinical presentation and an infiltrate seen on the chest x-ray. When there's a high clinical suspicion of pneumonia and the chest x-ray does not reveal an infiltrate, then you could do a CT chest. In addition, you could get serology for all the bacterial infections that we mentioned, the strep pneumonia, the mycoplasma, and even the viruses, cultures of the sputum. A CBC with differential, you will see the left shift if it's bacterial, or lymphocytosis if it's viral. You could see leukocytosis. You could have elevated offset rate and CRP because this is an inflammatory process, or you could do bronchoscopy or thoracentesis of the fluid to analyze and determine if it's a transudate or an exudate, which most likely will be an exudate if it's pneumonia. This is a right lower lobe pneumonia, and when it's more advanced, you get the actual effusion, pleural effusion, right here. Okay, so the guideline for treatment says that if you are, let's come to this one first, if you are a child younger than 5 years of age, then if it's 4 to 5 years, amoxicillin is the best choice. Even up to 5 years, but if you're suspecting chlamydia in this population, erythromycin will be the best. Now going backwards, if you are school-age children, the guideline says that azithromycin, clarithromycin, or erythromycin are your best choice, even though you could still use amoxicillin. So, younger than 5, amoxicillin. Older than 5, azithromycin, clarithromycin, or erythromycin. That's what the guideline says, AANP guideline. So when do you hospitalize the patient, or when would the parents should be concerned of complications? If there is severe respiratory distress, remember the vital signs that we discussed earlier. If there is hypoxemia, if there is any toxic appearance of the child, any failure to respond to the antibiotic more than 72 hours, if there is any feeding issues or signs of dehydration. Again, this is the guideline. Hospitalized antimicrobial treatment. I know that you wouldn't target hospitals, but ampicillin, look, always is a beta-lactam. So ampicillin or amoxicillin, but amoxicillin is orally, so you have to go to the IV route, which is ampicillin the first choice, or any type of third generation cephalosporin. And if the patient is allergic, or if you're suspecting chlamydia, then a macrolide antibiotic, which is azithromycin. Okay. So if aspiration pneumonia is also suspected, then you start clindamycin. So again, going back, any beta-lactam, including orally amoxicillin, IV ampicillin or cephalosporin. Okay. If you're suspecting if you're suspecting chlamydia, azithromycin. If you're allergic to penicillin, azithromycin. And if you are suspecting aspiration pneumonia, clindamycin. Remember, more than 5 years of age, azithromycin, clarithromycin. If you're less than that, then amoxicillin. In addition to that, you could use bronchodilator therapy. You should vaccinate the patients with influenza and pneumovaccine, fluids, and oxygen. In immunocompromised patients, you could do bronchoalveolar lavage, so basically bronchoscopy and do bronchoalveolar lavage and increase your spectrum. This is what the guideline said. This is very small, but I basically copy and pasted the guideline for you. So 60 days to 5 years, amoxicillin. If you are allergic to penicillin and you are not a type 1, you could still use beta-lactam, which is cephalosporins. If you are allergic to penicillin or you are 5 to 6 years of age, then azithromycin, clarithromycin, or erythromycin. Okay, this is prevention again. Now let's talk about bronchiolitis. Bronchiolitis is an acute viral infection of the lower respiratory tract in infants less than 24 months and is characterized by respiratory distress, wheezing, and crackles. Is most commonly and basically produced by the respiratory syncytial virus, and it's basically a single strain. The most virulent is the A strain. But parainfluenza could also produce it. Less frequent, influenza, and adenovirus, and even rhinoviruses, even measles could produce it. The virus spread from the upper respiratory tract to the small bronchiole, causing epithelial necrosis and inflammatory response that could lead to edema and exudate and even partial obstruction. The most pronounced on expiration and leads to alveolar air trapping and even complete obstruction of the airway could happen as well with atelectasis. The single most important pathogen again is the RSV. Occurs in 80% of cases and most of the time occurs as an outbreak in the winter and the spring. It's transmitted by droplets, by coughing or sneezing, or by direct contact with secretions. Even in countertops or rags or tissues or gloves, if you're in contact with that. Could be epidemic. The peak is in the first or second years of life. 50% of infants are affected by the first birthday, and reinfection could occur. Be attentive if the patient is in the daycare, if they have other siblings attending to preschool or school, because it's very common there, any crowding condition or low socioeconomic status, any low birth weight, any exposure to tobacco from parents. So if you're less than 1 year of age, if you have compromised cardiorespiratory status, if you're premature, if you have immunodeficiency or any congenital heart disease such as bronchopulmonary dysplasia, are risk factors for severe infection. From initial presentation of mild rhinorrhea, sore throat, cough, sneezing, for example, that could progress to air hunger and retractions and respiratory distress with apnea, crackles, and dyspnea that requires intubation. Diagnosis is suspected by history examination and occurrence of the illness as part of an epidemic. Symptoms similar to bronchiolitis can result from, for example, asthma, because asthma could also be precipitated by viral conditions. In addition, gastric reflux could also produce the same symptoms, or foreign body aspiration. Patients suspected of having bronchiolitis should undergo pulse oximetry to evaluate oxygenation. No further testing is required if it's mild disease. But if the patient has hypoxemia or severe respiratory distress, a chest x-ray supports the diagnosis and typically shows hyperinflated lungs, depressed diaphragm, prominent hilar marking, infiltrates could be also present. You could do an RSV rapid antigen test on nasal swab. Laboratory can give you leukocytosis as well. You could do an immunoassay or immunofluorescence. These are the differential diagnoses that I more or less explained. Treatment, very symptomatic. Prognosis is very excellent. Most children recover in 3 to 5 days. Although wheezing and cough could continue up to 4 weeks, mortality is less than 1%. Supportive treatment. Most children can be managed at home with hydration and comfort measures. Increased fluid intake and rest. You could do over-the-counter medications such as antipyretics. Never use aspirin in less than 18 years of age with flu-like symptoms. Wash hands frequently and limit visitors, and of course tell the parents not to smoke in front of the children. When parents should call physician, or when this is an indication for hospitalization. Of course, if there's an increased respiratory rate, accelerating respiratory distress, any ill appearance, cyanosis, lethargy, or fatigue, any apnea, any hypoxemia, any inadequate oral intake. If you have any underlying disorder of cardiac immunodeficiency, is very obvious, right? If you have sternal retraction or cyanosis, if you have signs or symptoms of dehydration, such as dry diapers, or an overall worsening appearance. So this is more or less what I explained, that you have to be very attentive because patients could lead to respiratory failure. Treatment is based on if the patient has any type of stridor, racemic epinephrine, but mainly bronchodilator therapy if there is any respiratory distress. Be attentive and a very close environment in case of failure because of need of intubation. In addition, you could add, this is for severe diseases, prednisone or solomedrol. As well, antiviral medications could be given with ribavirin, and even monoclonal antibody immunomodulators could be given as well, even though it's not commonly prescribed because of they're very, very expensive. Now let's talk about croup, laryngotracheobronchitis, and epiglottitis. Croup is an acute inflammation of the upper and lower tract, most commonly caused by parainfluenza type 1. Is characterized by a brassy barking cough. That you can't forget, that's croup. And also inspiratory stridor. Etiology again, parainfluenza virus type 1 are the most common. Less common, RSV, influenza, A and B, adenovirus, rhinovirus, etc. The infection basically causes inflammation of the larynx, trachea, bronchi, bronchioles, and even the parenchyma. The obstruction causes swelling and inflammatory exudates that develop and could even produce an edema of the subglottis and the glottis, tiring the patient and even producing atelectasis, increased work of breathing, and up to hypercapnia. These are the viruses that I discussed. It's very common in children 6 months to 5 years, and the males are highly affected, most commonly in the autumn. Signs and symptoms, usually preceded by an upper respiratory infection, barking, spasmodic, cough is present. Hoarseness then occur, commonly at night. Inspiratory stridor may be present as well. The child may awaken at night with respiratory distress, tachypnea, and retractions. In severe cases, cyanosis could also be present with shallow breathing. The child gets tired easily. The obvious respiratory distress and harsh inspiratory stridor are the most dramatic physical finding. Auscultation reveals prolonged inspiration and stridor. Rales also may be present, indicating lower airway involvement. Breath sounds may be diminished with atelectasis. Fever is present in about half, like 50%. The child's condition may seem to be to have improved in the morning, but again worsens at night. Recurrent episodes are often called spasmodic croup. Allergy or airway reactivity may play a role in this, but clinical manifestations cannot be differentiated from viral croup. So again, hard cough, sore throat, gets worse at night, drooling, heavy breathing, inspiratory stridor, brassy, barky cough, retractions, tripoding position. Now, this is the mainly differential diagnosis. We need to concentrate on epiglottitis. Diagnostic evaluations that you could do is basically an AP or lateral chest x-ray, and by the clinical presentation of barking cough and inspiratory stridor. Those two must be present. It's usually obvious by the barking cough. Similar inspiratory stridor can result from epiglottitis, or with retropharyngeal abscess. A foreign body could also produce it. If the diagnosis is unclear, do an apiolateral x-ray. There is subepiglottic narrowing that is called steeple sign, seen on an AP neck x-ray, and that supports a diagnosis. Seriously ill patients in whom epiglottitis is a concern should be examined in the operating room by appropriate specialist. Remember, you could put this patient in respiratory arrest. If it's mild, treatment is conservative with the same fluid, antipyretics, and calm. These patients should not be altered at all. Avoid crying. Educate the family about worsening of the symptoms. If there is moderate to severe, the patient must be hospitalized because there is high likelihood for intubation. Medications that must be used for stridor, racemic epinephrine, and high-dose dexamethasone, or in addition you could do prednisolone. Increasing or persistent respiratory distress is indicated by tachycardia, fatigue, cyanosis, hypoxemia, or even signs of dehydration. It requires hospitalization. Humidification devices such as cold steam vaporizers or humidifiers may help the airway as well. So hydration and antipyretics needs to be done in addition. The vast majority do not require hospitalization. The majority are mild. Almost all patients have full recovery. Okay? But it could be worse up to respiratory distress. So look for the complications of respiratory failure, or if there is a poor oral intake. If the patient is not responding to treatment, or if there's respiratory distress, you have to refer here, of course, to the hospital. Now, what is epiglottitis? Epiglottitis is a rapidly, progressively bacterial infection of the epiglottis and surrounding tissue that could lead to sudden respiratory obstruction and death. Acute life-threatening. It could cause cellulitis of the hypopharynx, narrowing the glottis opening. Most commonly produced by Haemophilus influenza type B. But in addition, you could have the presence of strep pneumonia, staph aureus, beta hemolytic streptococci, moraxella, etc., Klebsiella. Bacteria that have colonized the nasopharynx spread locally to the supraglottis, causing cellulitis. The inflamed structures mechanically obstruct the airway, increasing the work of breathing, causing respiratory failure. Clearance of inflammatory secretions is also impaired. So patients have a high fever of abrupt onset, sore throat, odynophagia, painful, dysphagia that is abruptly. So patients have a hot potato voice. They have rapid toxicity and respiratory distress. They are drooling. It's basically a few hours of onset. You have no chance. Signs of toxicity could include poor or absent eye contact of the child, failure to recognize parents, cyanosis, irritability, inability to be consoled, or distracted, dyspnea, tachypnea, stridor, patient is in tripod position. They could have also retractions, it quickly progress. So again, high fever, sore throat, difficulty swallowing. The child prefers to be sitting upright and leaning forward in tripod position. There's also an allergic component, but there's no significance. And here, change in voice quality, hot potato voice. Again, patient is anxious because in respiratory distress. They remain sitting, they're drooling, they have stridor, they have retraction. They could be cyanotic look for this, muffled voice. Okay, differential diagnosis could be either influenza that we discussed, foreign body aspiration that we discussed, and even the abscess. What could you do? CBC, basically showing leukocytosis. You could do cultures, but not of the epiglottics because that has to be in a very controlled environment. Don't touch the posterior pharynx. If in children with stridor, uh, you could do racemic epi. Um, the airway must be secure immediately. Okay, so airway management is your first approach. Securing the airway can be quite difficult and should, if possible, be done by experienced personnel in the operating room or anesthesia department. Usually required until patient has been stabilized for 24 to 48 hours. Alternative, you could do tracheostomy. Respiratory arrest, of course, you have to bag mask ventilating the patient temporarily. Oxygen, but it's basically by intubation. IV to give fluids to provide antibiotic treatment with beta-lactam antibiotics for Haemophilus influenza. You have to do sometimes, instead of intubation, emergency tracheostomy and fluid resuscitation. First line is a beta-lactam. You could use cefuroxime or ampicillin sulbactant. And second line, you could use chloramphenicol and even other types of penicillin. Mortality is 8%. So even though it looks a low number, it's very high. So you have to be very highly suspicious of it. Complications you could see from respiratory failure and arrest to pneumothorax and sepsis and shock. Now let's talk about asthma and influenza. I already discussed it. Remember, it's a chronic airway hyperresponsiveness that mast cell degranulate, releasing not only histamine but also inflammatory mediators such as leukotriene and other mediators such as the lymphocytes, thromboxane, that produced leakage and edema. It produces bronchoconstriction as well. The diagnosis is basically, because it's a recurring condition, you have the history of being exposed to an allergen or an infectious disease, most likely viral, and they respond to bronchodilator therapy or any other anti-inflammatory. Very common in children. Wheezing is not always present, but is very common physical finding. Mostly viral. 50% of children who have asthma subside after age of 6, and some others continuously wheeze. Many children, since this disease is hereditary, genetic, 60% have a family history of asthma and 20% remote or in one parent. In addition, look for any history of atopy, any eczema, any allergic rhinitis, any henofever. Remember, this is mostly an inflammatory response that produces hyperreactivity and mucus production by high levels of IgE and also eosinophils. Viral infection could produce it, particularly from respiratory syncytial virus. In addition, patients could manifest asthma as an atopy, such as eczema. Associated symptoms, coughing, and this cough is most likely dry, shortness of breath. Patients most likely is seasonal when they have symptoms most commonly at night. It could be triggered by either any type of allergens or an infectious process. Look for prior hospitalizations that could impact the asthma event. Asthma could have patients miss school and limit activity, such as exercise-induced asthma. Try to discontinue stuffed animal, have parents not to smoke, change floors from carpeting or move out. Pulmonary examination, it could be completely normal, or patients could have retraction due to respiratory distress. Remember, this is hyper expansion and hyperinflation. This is a chronic obstructive pulmonary disease that produces an increased AP diameter of the chest, producing barrel chest shape. Patients could be from decreased breath sounds to bronchitis to wheezing, using expiratory effort, having prolonged expiratory effort as well. Um, Remember that these patients tend to have associated allergic rhinitis, so they have the typical sign of allergic Chiner. It's basically the tip of the nose constantly being rubbed, nasal congestion, allergic conjunctivitis with watery eyes. Skin-wise, they could have eczema, a clubbing, because patients could have chronic hypoxemia as well. Infectious process could precipitate it, and differential diagnosis could be bronchiolitis and laryngotracheal bronchitis, including pneumonia as well, but the x-ray will be completely normal. Another differential diagnosis is foreign body aspiration, most likely unilateral with malodor discharge. Others, chronic obstructive pulmonary diseases such as cystic fibrosis could be included. How is it diagnosed? The only way to diagnose asthma is by doing a pulmonary function test. And the values that you would encounter will be a decreased FEV1, and I will discuss this in class face to face. In addition, you could do an exercise challenge test or cold air exposure if the patient has an exercise-induced asthma. In the past, we used to do methacholine, which is basically a bronchoconstrictor to see the amount of hyperreactivity that the patient has, but this was leading to respiratory failure in the past. You could do allergy testing as well. Peak flow meter is done to basically diagnose as well as to understand the recovery and progression of the disease. Remember that green is 80% of baseline, yellow is 50 to 80%, and red, which patient must be in the hospital, is 50%, and yellow is caution. What else can you do? Chest x-ray is completely normal in asthma. If you're suspecting other diseases such as pneumonia, you must do a CAT scan of the chest. Other diagnostic evaluations is basically to rule out differential diagnosis such as a foreign body, mucus plug, or cystic fibrosis, or bronchial dysplasia. You could do bronchoscopy. Remember the stepwise approach. If we come back to this slide, beta-2 agonists are the first line, followed by low inhaled corticosteroids. You start increasing dosages before you go to long-acting beta agonists. And then last choice would be adjuvants such as leukotriene modifiers, mast cell stabilizers, or corticosteroids. Corticosteroids are never orally the first choice. Fluticasone, budesonide, clometazone, inhaler it is, but not orally or IV. I will talk about this in class with case studies. Management, again, look for severity of the disease. Beta-2 agonist is your first initial choice, even for exercise-induced asthma. How do you know if the patient responds to treatment? Well, if there is subsides of the symptoms after beta-2 agonist, albuterol or levobuterol, if the peak expiratory flow is more than 80% predicted. If it's incomplete, the symptoms return to the wheezing and the shortness of breath, etc., or cough in less than 3 hours, and the peak flow is 60 to 80%, or poor if the peak flow is less than 60% and symptoms persist. Again, beta-2 agonists every 3 to 4 hours in an attack. Okay, and again, inhale corticosteroids, then you increase the dose, then You could do adjuvants of treatment, add LAVA, and then at the end, oral or IV corticosteroids. In addition, you could do immunomodulators at the end. Very, very expensive. Refer even to the hospital when the patient has impending respiratory distress, any type of airway obstruction, or clinical signs that suggest any other pulmonary process. If you have increase of symptoms, if you have exercise limitation, if your peak flow is decreasing and not improving, you should be hospitalized or impending alerts. So basically, try to recognize what is giving you the asthma. If the patient is reluctant to be labeled as asthmatic, you could, change to reactive airway disease. Try not to use antibiotic. It's not for asthma attack. This is basically if you're suspecting pneumonia and bacterial pneumonia. Remember that infectious process could trigger an exacerbation of asthma. Do an x-ray to rule that out, but it's not mandatory if there's no signs of fever or infectious process. Tell the child that they could continue playing sports, that beta-2 agonists could be given before exercise. Try to educate them of poor adherence, and also the use of inhalers properly. They can participate in sport, educate them that this is a chronic condition, explain the benefits and the side effect of all the medications, and try to make a plan in writing. Try to answer those questions, mainly to the mother. Does the steroids will affect the growth? Most of the time the childs don't have to be on chronic steroid use, so this is temporary, unless it's inhaled. Explain the side effects. Explain that long-acting beta agonists are for life. That is not to be discontinued. Only short actings are for outbreaks. Now let's talk a little bit about cystic fibrosis. It's an inherited disease of the exocrine glands, affecting primarily the GI and respiratory system. Etiology is basically by an autosomal recessive trait. The responsible gene is the chromosome 7 that encodes the membrane-associated protein called the cystic fibrosis transmembrane conductance regulator, or CFTR. The most common gene is again a mutation that has been identified in chromosome 7, and what this transmembrane conductase regulator does is that is an CAMP regulator chloride channel, resulting in chloride and sodium transport across the epithelial membrane. Disease manifests only in homozygotes, but heterozygote could have the disease process and be carriers only. Nearly all exocrine glands are affected in various distribution and severity. They become obstructed by viscous, solid material that could be in the pancreas, in the intestine, in the bile duct, in the gallbladder, maxillary gland. They produce excessive secretions in the tracheobronchial, and they also appear histologically secreting excessive amount of sodium and chloride in the sweat glands, in the parotid gland, and salivary glands. Although the lungs are generally histologically normal at birth, most patients develop pulmonary disease beginning in infancy and early childhood, with mucus plugging and chronic bacterial infection, accompanied by airway reactive disease, bronchiectasis, and exacerbations of respiratory distress, with mucopurulent plugging and a lot of infections. The lungs of most patients are colonized by Staph aureus and even Pseudomonas. In the GI, the pancreas and intestine are frequently affected. Exocrine pancreatic function is compromised. Um, they have duodenal fluid also, and accumulated bile duct involvement with plugging and hepatic fibrosis. Um, 50% of patients have recurrent or chronic infections with cough, sputum production, wheezing. Um, Cough is the most troublesome complaint, with gagging and disturbing sleep. They could have viral chest deformity with digital clubbing, recurrent sinusitis. The neonate would have meconium ileus, with which is the earliest sign for them. Um, Malnourished as well, with pancreatic insufficiency, foul smelling, bulky, oily stools with abdominal protuberance. Universal diagnosis is by screening. So the newborn screen may also be suggested by a positive prenatal screening test result, family history, or symptomatic presentation. It's confirmed by a sweat test showing elevated sweat chloride on more than 2 occasions. So basically, in this test, uh, it's stimulated by pilocarpine, and the amount of sweat is measured, and the chloride concentration is determined. Less than 6 months, normal chloride, for example, so you can have an idea, is less than 29, and more than 6 months is less than 39. So these patients tend to be higher than that. If it's, for example, severe, they have more than 60. In the neonate, less than 6 months, and more than 6 months, again, more than 60 is the parameter. You could do chest x-rays as well, but shows, exacerbations and bronchiectasis. You could do pulmonary function test. It's also an obstructive pulmonary disease. Prognosis is very poor. Deterioration of this disease is not avoided. There's a comprehensive and multidisciplinary support. Many physicians and practitioners involved. Treatment of pulmonary problems centers in prevention of airway obstruction and prophylaxis of pulmonary infections such as Haemophilus influenza, so antibiotic should be given. Prevention with annual influenza vaccination. A lot of mucus clearance with daily percussion, vibration, postural drainage. Um, Basically, air humidifiers, positive expiratory pressure devices, regular aerobic exercise is recommended if the child is big enough. Inhaled corticosteroids are usually not effective. Oxygen therapy most likely will be used. These patients tend to die with pneumonia on mechanical ventilators. Oral corticosteroids are indicated in infants with prolonged bronchiolitis and bronchospasm. Antibiotics, again, beta-lactams, but include as well erythromycin could be given, but this is more anaerobic, so you would see that these patients are treated as well with linezolid Zybox, chloramphenicol, tobramycin, even Genta and Vanco. Mucomist is very important to give. Pancreatic enzymes replacement. Diet includes sufficient calories and protein to promote normal growth. And surgery, even for bronchoscopies and atelectasis, nasal polyps, gallbladder disease, and at the end of life care. They tend to die early. This is the end of the presentation, and I hope you enjoyed it. We'll have a face-to-face case study presentation as well.